ultimately what we're dealing with are the symptoms of a deeper malaise, and it's a sort of social disease. To a large extent, people are responding to the stresses of their daily lives, and they're seeking escape and avoidance. And so drugs and alcohol are the answer. You know, Obviously, in a low socioeconomic subset of the population, we have to fix those real life problems in order to alleviate the symptoms. But as long as we sort of treat a sort of chronic condition with sort of acute type of care, we're just putting band-aids on the problem, and it's not going to get better.
Andrew Sidoli Msw is the Executive Director of True North Behavioral Health and a Senior Consultant at C4 Consulting. Andrew is a certified addiction counselor and clinical social worker, steeped in psychodynamic and attachment training, and is a practitioner of EMDR. He has an extensive 20-year background in a multitude of chemical dependency and mental health settings.
My name's Andrew Sidoli, and I am a licensed clinical social worker and certified addiction specialist. I came to these shores. I came to Boston, Massachusetts in 1989 to attend a community college to get a degree in substance abuse counseling. Well, I had a bit of a checkered past in my adolescence and discovered the joys of the 12-step and Minnesota model of treatment in London. I came from a family of therapists, so both my mom and dad had had a lot of therapy. They both trained in psychoanalysis. My mom went on to practice for 20 years. My dad then went back into other occupations. He decided he didn't want to be a psychoanalyst. So when I attended my first group therapy, it was just like, it just felt very, very normal. It seemed like it was just an extension of a conversation at the kitchen table, and I was aware of the dynamics and everything that was going on. So I expressed a wish to my counselor. I said, I'd really like this. I think I'd like to do what you do. And she said, well, wait a while, stay clean and then go to the States. And so at the time, before the internet, and I think I went to a public library, and there was a list of American colleges, and I found the programs, and I called around, and there was a choice of Boston, Minneapolis, and someplace in California. And I thought, Boston was the most obvious place. So I came here, and it was a fantastic program. I got a better training then than I did subsequently in a clinical social work program. All our sessions were filmed. We were given feedback. We had to do, as interns, we did sessions in front of a clinical supervisor. It was a really thorough program. And we were required to be in therapy while we were in the program, which is my pet peeve about what happens in treatment these days.
You mentioned the Minnesota model of treatment.
Yeah.
Could you explain to us what that is?
Yeah, I mean, it was novel in the sense that it was really based on the 12 steps, and there was a lot of group therapy, and it was led by professional therapists, and integrated a lot of the 12-step traditions and principles. Up to that point, well, first of all, I didn't know much about sort of treatment. I heard every now and again somebody got shipped off to the States or Canada, and they went off for 3 or 4 years to these sort of very, very long-term, TCs, as they were called then. And they were communities, and they were therapeutic communities where all sorts of, behavior modification models were used. And I heard of people who had been sort of, kind of shut in rooms and sort of tied down, and there were no detoxes or doctors. I mean, it was just common back then, and it was a very sort of punitive model. And that had been the model in Britain as well, and so this was very new as a treatment modality, and so I had a great 2 years in community college. It was my first sort of experience of working in the States and living in the States, and felt very, very welcomed by the sort of people in the community. And I worked in Lynn, which was a very, very low income town. And I worked for a nonprofit that was basically working with a very underserved population, of which about a third came out of the federal prison system as part of a jail diversion program. So I feel like I cut my teeth on that population, and I'm not sure how effective I was. Here I was, and sort of a young man with a little bit of recovery under his belt, well-meaning, couldn't really identify with some of the social problems and the experiences that some of these patients had. I had gang members from Chicago and New York City who had who had done some and had terrible things done to them, and but I was curious, and I think that that has been a sustaining thing in for me as a therapist, as a counselor, and just as a human being. I was genuinely interested in their stories, and that's what I found fascinating about this industry. Even though the issues are very, very similar from patient to patient, everybody has really, really different stories, and I never cease to marvel at the resiliency that people have and find, and the growth that people kind of bring to bear, and how individuals sort of power through. I went to New Mexico. I got a degree in child development, a degree in clinical social work. I've worked in detoxes and psych hospitals. I've worked in private practice. I've worked with the homeless. I've worked with reintegration programs with veterans, really, and private pay, high-end facilities, working with the sort of young adults and children of middle class and very wealthy America. I think the most rewarding was actually working with the homeless. I was really quite surprised because part of my orientation, and this was a national organization called Healthcare for the Homeless, and part of the orientation was sort of being asked, why do you think most people become homeless? And I was convinced that it was sort of drugs and mental health problems. And in fact, for the older population, sort of 30 and above, actually divorce had been a primary factor. And so really understanding much more really social determinants of health, both mental health and physical health, really became part of the passion. And I was running a residential facility. It was a 12-bed facility for men, 9 months, and that are had been in place for a while, and was really, really successful. They provided medical, dental, wraparound services, case management, psychosocial rehabilitation, and I got to see really quite a varied sort of population. Well, I think we moved away also from the idea that we're not going to provide services unless you get clean and sober. Basically, we know from other countries' examples that when you actually provide a level of stabilization for an individual, that actually promotes, momentum. And, there is this whole conversation about early engagement, some people call it harm reduction, but this has been going on in Europe for decades, and we're in the middle of tens of thousands of people who die, and We don't provide safe injection sites, and we don't sort of really, we have a very binary approach. I think partly it's cultural, I think, in America, because America tends to be very black and white and very fundamental about its sort of its approaches to pretty much anything. But in communities where you supply the housing first, then the social services come and individuals are stabilized, and then they're able to get on their feet. But it's impossible to ask somebody to get clean and sober when they don't have the bare necessities of life. So I mean, I saw that with homelessness. Certainly have seen it with, as I said, early engagement, whether that's through sort of the court system or whether that's through MAT. I mean, it's unbelievable that, we're still sort of discussing the pros and cons, and there are facilities who basically say, we don't believe in medication-assisted treatment, the use of, buprenorphine, or, I mean, there is a moral stigma that's attached to people using medications. And that's sort of part of this fundamentalist approach. It's almost a religious doctrine. It's like you're abstinent or you're not, without understanding that there's a whole spectrum in between. And I think that has caused damage and has done harm. The other thing too is that, I mean, as a therapist, I have been committed to both a recovery path and a therapeutic path. And I think that I think it was actually a legal challenge in America to a college that required its applicants to undergo therapy, and basically, it was considered to be unconstitutional. So they couldn't make it a requirement anymore. In Europe, it's common practice. So now people are basically coming out of master's programs without having had a day of therapy, of their own therapy in their life. And I personally believe it's absolutely impossible to do counseling or therapy if you're not in therapy yourself. And in the industry, we tend to say, well, you're under supervision, but there's no real clinical supervision that's given to individuals. It's always performance-based, it's task-oriented, it's about the job. It's not about the process that the individual is going through. So people are working with massive blind spots. They're being activated. There's a lot of people are in high states of burnout, and they can't really be effective in that state. We're at a sort of flex point in this industry where, and it's happened before in the 80s, and I think it's going to happen again. We're not really getting significant outcomes. In fact, outcomes haven't really sort of budged very much in 50, 60 years, despite tons of research. Money and sort of the industry as such has favored traveling to destination facilities, and then it's not that effective. And then when you have the sort of requirements, especially when you're dealing with insurance, of people only getting 30, 40 days, it's really not sufficient. It would actually be a better use of resources would be treating people in their communities with wraparound services, getting their families involved, and making the communities actual treatment communities. But that has to involve a level of, stakeholders, employers, and the police, and so on and so forth. Everybody has to be involved in that. But the idea of going to a different state for 30 days, and then just coming back, your family's not being treated, you haven't, you're just going back into the same environment. It's very difficult to make it effective. I mean, the hospital should really be the first place of engagement for a substance use disorder. I mean, the emergency rooms see daily patients coming in, and that's really where the early engagement process should be happening. Whether it's Suboxone or methadone or referral, somebody should be stationed in every emergency room in America to engage with patients. But they're sort of discharged, and then they're back in the street. I've worked in communities where the county detox had beds open for the police, and the police could just basically, they knew they had a number of beds, and they would bring them just off the street, with the idea of trying to detox them or stabilize them and provide supportive services. I mean, I think, there's starting to be a shift, but I think that we still are belaboring under a lot of stigma. I mean, the American culture as a whole is sort of pull yourself up by the bootstraps, and there's, I think we've all internalized a sense that if we're not successful, it's because we're not really working hard enough. Ultimately, what we're dealing with are the symptoms of a deeper malaise, and it's a sort of social disease. To a large extent, people are responding to the stresses of their daily lives, and they're seeking escape and avoidance. And so drugs and alcohol are the answer. Obviously, in a low socioeconomic subset of the population, we have to fix those real life problems in order to alleviate the symptoms. But as long as we sort of treat a sort of chronic condition with sort of acute type of care, we're just putting Band-Aids on the problem, and it's not going to get better. I think everybody who's been in this field for a while knows that, the sort of a recovery-oriented system of care goes at least 5 years, and that's really how long it takes for everything to settle down and for individuals to be able to really deal with their trauma and get to a level of self-esteem that they're able to manage relationships and manage employment and become sort of pillars of their community, become resources to the community. But, when we sort of only provide detox or only 15 days or only 30 days, and it's not that I'm blaming the insurance companies, after all, somebody has to pay for this. But under a system where sort of healthcare is actually for all, like it is in Europe, then I think it would take sort of financial incentives out of the system for everybody, whether it's a pharmaceutical company, it's a healthcare company, or it's an operator, right? Facilities in Europe have to, they have to apply for certification, and they are required to provide outcomes in order to keep getting funding. So it's a different sort of incentive. Here, anybody, and the plenty of well-meaning people, it's not about bad operators necessarily, although there are plenty of those, but it's really about the fact that there's no, anybody can just open up a treatment center and be paid for it. I would like to think that I have added something to the conversation, that somehow we've all worked together to raise the standard just a little higher. Whether in substance abuse treatment and trauma care or dual diagnosis, whatever the focus, that we've done our best to engage and to try to change the system for the better.